So we can start now with the discussion portion of this. We have a representative from NIAID, Donna Love, and we've got Megan Lyman from CDC, and then Louisa Ostrowski-Zeichner from UT Houston and the MSG. Lisa.
Hi, I'm Lisa Tushla from Terra Nova, and I've enjoyed working with the entire group. And actually, one of the outputs of the collaboration with the COAG that I kind of threw in the IDSA bucket was Mucormycosis podcast that Alon Schwartz and Andre Speck put together. And that was just reflective more of how the CDC brought different stakeholders to the table on some collaborative programming, and we also started to work with the Valley Fever Institute on some cocci programming. So I was wondering if Megan could talk a little bit about how the COAG supported those outside collaborations.
I can try. I'm not sure I'm the best person, but you know, I think this is great because in MSG, there's so many clinical and research partners. A lot of our partners are public health. And so, you know, especially with Valley Fever Institute, who I haven't worked personally with because I don't do as much on endemic mycoses, but I do think that we maybe have more partners who are doing primarily public health work, and maybe that's facet of the conversation that we can pull in. Health departments, we work a lot with other people that might have a slightly different aim and aren't as involved in research or clinical practice, but I think that they can have a good perspective and access to input that I think would be helpful for educational activities.
Thank you. Thank you.
Okay, Lisa. John?
Well, thanks. First of all, I got two questions. One for Donna, and I wanted to emphasize Donna's been to these meetings a lot, and I think it's important that you understand that she's very enthusiastic for mycology. She puts the things up there. Sometimes I think we don't utilize that as well as we should. She put a lot of programs up there. And they're our advocates. So the only way she can work on these things is if we deliver something. And so I think she's trying to encourage that, and we appreciate her being here. I want to ask two questions to her. Number one was, maybe it was me, but the ARLG kind of comes out of Duke and stuff like that with Vance Fowler. And I thought when I pushed him pretty hard on the last submission that fungi were in that program. You mentioned that there weren't, maybe I just didn't read it, and I need the next submission to push harder because I believe the ARLG and stuff is a growing feature. Antibiotic resistance is going to be maybe the new AIDS of funding and stuff like that for the future. And boy, oh boy, just as Tom Chiller's done it for C. aureus and stuff like that, if we're not getting in the train of drug resistance, it's going to leave us behind. So I just wanted to ask her did I miss that or?
I don't think you missed it. I don't know. You should talk to the folks at Duke and see what their views are.
No. Well, I talked to them. I said put that in the last submission.
Yeah, it's my understanding they decide what kinds of studies they run. So I've certainly pushed on my end, but
yeah, I didn't mean that's right. It's still decided after they do that. But in the grant, when they did the thing, it was in the area that you could potentially apply for money from antifungal resistance.
Yeah, I think it is potential. So sometimes my job as a program officer is to steer folks in the right direction. So I don't want, you don't want to be wasting your time applying for something when there is a slim possibility, but maybe your time would be better spent. So that's why I emphasize the other mechanisms. But I do want to put it out there because I think you're right. Technically, it was in there, but I'm not sure that they've done anything to date.
I agree with that. But I think for us, we got to continue to advocate for that. And that ship, we better be sailing on it.
Right. And I would just, again, I know I just want to plug the CDC and all of their efforts to get fungi on the table in terms of antimicrobial resistance and getting fungi included on the 2019 threat list, et cetera, because those lists are used by NIH and NIAID in particular. So I think it's right. I think you as a community, you always need to be looking for opportunities and making sure that you're part of the conversation with these hot topics.
The other question I have for you is, I think, again, they don't utilize as well all those different groups of things that can be used in development of drugs and everything else. And I may have messed it up there, and it may not be access. And I'm not sure exactly how to do this, but I think one of the areas, as I've talked about a lot on this, is statistical support. And I wondered whether NIH really had this type of thing. I mean, even our own institution, they fight over a statistician, and then at the end, the statistician never does what they want, and it goes on and on. But it's an important issue of big data, et cetera, and I was wondering whether the kind of statistical support where some young investigator or even old investigator could go and get access. Of course, the statisticians never like that in the beginning because they don't want you to come with your data. They want to be able to help you decide on how to do that. But I just didn't see, is there a group, or did I just miss that?
Yeah, I didn't list a group. I think there is actually a group of statisticians within NIAID. And when you mentioned big data, we also have some calls out for data knowledge bases, which I think this community could think creatively and apply for. I didn't have it on there, but I'd be happy to chat with folks about that. So we do have a whole office of data something, which I think the medical mycology hasn't cracked open yet, but I would be enthusiastic to help you try.
One more quick question, not for Donna, but this is for Louis and Megan. Very impressive work on getting this COAG thing together. I think it's pretty incredible, and it was used and utilized by Tom and the CDC, MSG to do things, and they've been very, very productive. What I want to understand a little bit, and it's always hard, as Yogi Berra says, to predict the future and all that stuff, but do you have an anticipation of a plan going forward after that money of that COVID thing came in and you're really all set up, you're ready to go, you're doing the things, but then all of a sudden it kind of peters out because there's no resources around for them to continue that? Because again, all the energy you put in right now can then be utilized for continuous work, advocacy, education, et cetera, et cetera. So is there any 5-year plan on this?
Yeah, sure. I mean, that's obviously the goal, and I don't think when this was originally created that it was even based on COVID money. I think that a lot of the needs that arose at the time ended up being COVID at the beginning, but I think that's the hope, and we want to nurture this relationship and have it sustainable, so our hope is to provide sustainable funds so that these things can continue. But, sometimes it's hard to predict the future, and Tom and the admin team at CDC are better than most at really trying to strategize and play the game and, get funds where they can. And I think that we've really benefited from MSG's help in that department. So I think even from the financial aspect, it's been really a great collaboration.
I think, the educational effort was launched and it was very successful. And at this point, I think we need to sustain the educational activities and address new needs as they come in. But we need to start steering towards the other part of this, which was the endemic mycosis. We need to start addressing maybe some surveillance or point prevalence studies. We need to, again, this COAG right now doesn't allow for clinical research, but maybe in the future it will. Another sort of resistance projects. And also I see sustaining the educational mission and then delving into projects. And I think that's the future of the COAG.
D.
Good morning. First of all, thank you, Donna, for everything you do for our field, and your presence is very inspiring. I was a little bit disappointed with the pie you saw about the majority being Candida, Aspergillus, and endemics, because maybe I'm biased, but if you put 3 criteria of what are the needs, total mortality, lack of available drugs, and costly disease, dollars per hospitalization and readmission rate, mucormycosis is number 1, number 2, number 3, number 4. And I'm not sure what you can do for that, because this is the lethal disease. It's not, I mean, obviously, I practice in a hospital when we see a lot of it. But if you put this criteria, and if you start putting criteria, objective criteria like that, what is the most lethal disease, the most costly disease, the lack of available drugs, then you can rearrange the pie and give opportunity for innovative research. That's one point I wanted to make, because it's a major problem, the way I see it. And the second question I had for the CDC and Luis, maybe this reflects a philosophical aspect that you see in academic medicine, but clinical productivity, RVUs, scholarly productivity, grants, papers. When it comes to education, what are the metrics that matter other than people logging on a Twitter and touching this? How you assess value of this education in long term? What are your thoughts in the era of, social media? How you capture value in long term?
I guess I can answer your first question about Mucor and the way we balance the portfolio, and I agree with you. I think one thing that's been hard for me in advocating for sort of, I call them, I don't know, my sort of lesser pathogens or ones that aren't studied as much, is, I need numbers, the actual numbers, morbidity, mortality. When I took this position, I was a little surprised because it seems like folks in the in tropical medicine are quite good at advocating and getting DALYs and numbers. And I know that David Denning has done a lot of work in this regard to kind of elevate the burden of disease for fungi and fungal diseases. But that's one thing that sort of speaks. If I go to my leadership and say that, fungal diseases are on par with tuberculosis, I'm not sure they'll take me seriously, honestly. So, I mean, I guess I'm asking you guys for more publications or more resources to point to.
We can provide to you this week. It's already there for many years.
I do hear you. And another thing that what I mentioned was, because we're pay line driven, it is, these areas that are already big and very deep tend to do better during review. And so it is a challenge, there's no doubt about it. But there are opportunities to put out notices of special interest to kind of encourage folks to put in these applications. Exactly, yeah. Yeah.
To address your second question, I'm going to put on my faculty hat now, leadership, and the world is changing. It used to be about citations and H-scores and bringing book chapters and annotated bibliographies in your CV. But now promotion and tenure committees are looking at Twitter. They're looking at your followers, at your activity. They're looking at altmetric scores more than H-scores. They're looking at DOIs, and we have been focusing on MSG to be able to provide DOIs for everything you do in Dr. Fungus, the case of the month. They look at impressions. So the world is changing, and we need to adapt to that. And I'm very happy to really report that promotion and tenure committees are changing as well, and they're looking at these new things. Mm-hmm.
Lisa, can I ask you to come to the mic and just, can you address this question as well from a pre-test and post-test assessment? Because, I mean, traditionally we've done for CME, there's a pre-test assessment and then a post-test assessment. What's being done with these programs with respect to that, to at least partially address Demetrius's point about how do we know how effective this is?
Yeah, and I think the pre-test, post-test in the CME environment, but we've also embedded a ton of polling questions through these webinar series. So part of it is learning what's going on in the community. But we've also started to, for year 3, look at a quality improvement initiative around these endemic mycoses. So if someone implements this, does it make a difference? So the lines, as Luis suggested, between the traditional educational model and actually getting to some research aspects of it as well are important. So we are starting to do quality improvement.
And I'll just add that I think that it's really challenging. Obviously, the goal is to drive change in practice, and sometimes that feels like it's very far down the line and hard to kind of, you want to capture that impact, but it's challenging. But I do think there are some activities where that is the goal, like thinking about the endemics algorithm and how the idea to pilot it and actually look at how it's changing practice and, measure that is a good example, and maybe we can do more of that to actually look at, not just participation, but impact on practice.
Jay.
The gentleman was before me.
Oh, I'm sorry.
Yeah,
Peter,
so
Peter.
again, coming back to education and some AI, coming back to my point with Peter of having 0 deaths from Cryptococcus, one of the biggest things is delay in diagnosis, and our patient population has been so frustrated by this. I think the greatest case was one went 24 months. His wife had divorced him because you're lying on the couch all the time, got admitted to a psych hospital. Finally, someone did an LP, and, oh, you've got fungus growing in your brain, that's why you're depressed. Now he's fine. And now you can diagnose that with a blood test. You don't even need to do an LP. So what they did, they formed their own website, and they've been able to drive questions to their website with simple questions. Because as you know, and that's what I wondered, should we expand into the general population and not trust the medical infrastructure so much? So if you've gone to the ER 3 times and they haven't made the diagnosis, and you have a terrible headache and your hearing is beginning to go, you're going to get on the internet and you're going to do that. And to work with Google, and that's one thing we've been having, is to drive intelligent algorithms to your website. And we've actually had patients who've done that, gone to our website, gone to the ER and said, I want a cryptococcal antigen, and I'm not leaving until I do. Made their own diagnosis, and called us up, got them, when they failed therapy, transferred to NIH, we got them steroids. They got over their thing. So they're being driven by the patients. They're intelligent. They get on the, that's the first thing you do. Is there any way to maybe coordinate with Google and get these, because that's the hard thing, is driving an intelligent algorithm to these kind of things, not just general education.
I'm going to answer your question partly, and then I'm going to defer to Lisa and then some of our panelists. But our educational scope includes, increased public awareness, but also advocacy.
Yeah.
The advocacy piece we have addressed in faces of fungal infection, the interviews, et cetera. I think it's still an issue of getting it out into the public. But we've been talking about this over the last really several months, but especially over the last few days. Lisa, you want to?
Yeah, one of the things that we did was to use a Google ad grant associated with the MSG being a 501c3. And so we've been very cognizant of increasing patient access to our materials, and we have a separate portal on that. So I think the Google ad grant is enabling us to make sure we're like one of the first things that people see. But we're also working with Dallas and Mitsuru at the CDC to make sure what the CDC is offering has really good materials for patients as well, because we've been mapping where patients go to get information. So we're very much aware of the algorithm.
But I was wondering with the pre-diagnosis, they don't go, with crypto, they're not looking for crypto. They're looking for headache. They're looking for, I've got the worst headache in my life. My hearing's going downhill. They never heard of Cryptococcus.
Yeah.
They never heard of histo. That's what I'm saying. Can we go that kind of depth? Is that possible?
Yeah, because the Google ad grant lets us to map to the terms that patients look up. So
that would be
headache,
awesome.
Stiff neck or other factors. So I think the Google ad grant, and we should be looking at that more carefully. And we're actually going to be sitting with the CDC in a couple weeks looking at those outcomes. But, we have a lot of video series of patients, and what is cool is they'll say to us, I didn't realize that someone has blastomycosis is going through a similar thing that I'm going through with histoplasmosis. So getting those patients and working with our advocacy partners is important.
Yeah, that's really key.
So I haven't looked at statistics lately. Maybe GR or the Dr. Fungus team can comment, but the most utilized feature of Dr. Fungus forever has been the nomenclature. But one of the second most used features is the sick building syndrome. And this is patients looking for, the mold caused my headache, right? So we definitely have a presence with patients, and I agree with you, we need to build it up.
Yeah, that was great. The second question I had is to Donna. Donna, you've done a fantastic job. I'm going to ask a dangerous question and one that scares me, and that is, how can Intramural better serve the extramural community? Because in the past, we've always sort of acted as competition, and it's kind of stupid. What do you think? Have you ever heard any ideas of how we can be better used?
I think I think you all are collaborating with Extramural, which, and the wealth of resources that you have in Intramural that can help these applications. And as you know, there used to be sort of a cooperative special call that has been sort of downsized lately. But I think it is a challenge. I mean, you do have all of this clinical capacity, and it seems like very unusual resources that could be leveraged better in the community. So I don't know, maybe we should get together.
Keep thinking. There.
Yeah.
Okay. Jay?
Jay Aram, Melenta. In my question is about MSG and potential role in legislation and WHO priorities. As you think about the answer, I was part of a group invited in my previous company that I worked with to help with the Pasture Act to add antifungals to the incentives. And also in a meeting with WHO, somebody challenged me that I was reminded, tell us why we should care about mycology. You don't even have good epidemiology.
I can start. I mean, we have spent a ton of time in Congress, not so much through IDSA. I think we were, a couple of us were asked with IDSA when they were asking to help the GAIN Act go through. Some were recruited to talk to subcommittees of Congress to talk about antimicrobial resistance. I was asked to talk about the importance of fungus. We were lucky enough that actually, was attached to the GAIN Act, and so the GAIN Act, which was passed sometime in 2013 or something, is that about right? I mean, I think it's part of the reason we're seeing some of the products that we are now. We don't have, and so access to Congress is each one of us, through our local representatives and through our universities who all have lobbying groups, can access a Congress. My situation was unique because Senator Shelby, who's from Alabama, was head of appropriations. That goes away this year. He's retiring at 89. But we don't have such access to the WHO. I mean, we do through some of our members, for instance. I'm sure Tom Harrison and David Bulwer and others, have access. But we have not been invited to that table, and in the past we've kind of waited for that. I suppose we could beat the door down, I suppose, but I think we've tended to keep our efforts closer to home as it relates to that. So through IDSA, through Congress, and then of course now we have a voice with CDC as well. So, Luis, do you have can you add to that?
It was very interesting with WHO when they did the call for volunteers for the essential medicines or essential diagnostics. The person that was working with us really told us, oh, if you have any conflict of interest, don't even bother applying. Nope. They don't want you there. So none of us applied really to be in that committee. And lo and behold, after the fact, we found out a bunch of people had conflicts, mainly European, and they were allowed to go into the committee. So I think it's a learning curve for us as to how WHO works, but it's definitely on our radar. We need to do that level of advocacy.
Yep. Ashraf, and then Rob.
Thank you. So I just want to comment on what Demetrius just mentioned, and I would like to start by saying thank you, Donna, for what you've been doing, because in a very short period of time, you've done a lot to the mycology community, and that also goes to the same thing to the CDC, Megan, Sean, and Tom as well. So we do have actual data on lethality of mucormycosis and the cost of caring for mucormycosis that comes at least from 2 independent studies conducted by Demetrius' lab and my lab. And we do collaborate on many things, but we did not collaborate on these things. And we came pretty much to the same conclusion that the cost is approximately $100,000 per patient. This is on average. I also would like to say that the PCS service, the preclinical service, you actually pointed me to it, and we are now quite benefiting from that as well, as you know. So the other thing that a lot of people don't understand, that mucormycosis can be extremely profitable in terms of basically industry investing in it when it comes to biologics, because biologics are expensive and it can be very profitable. There has been a study conducted on our product for Vitalix by independent Foresight, which is contracted by the NIH, concluding that the market can be as high as $300 million only in neutropenic patients. So there are opportunities there, but I think we need to educate people. Thank you.
Okay. I guess our last question will be Rob, and then we'll break for lunch. Go ahead.
Actually, I wanted to comment, if you don't mind. So Pasture and advocacy is really my basket. So there is a lot of advocacy going on for Pasture. And on the fungal side, there is a sister bill called the Forward Act that is focused specifically on fungal diseases. Both are moving through Congress. Both have a lot of advocacy currently ongoing. I know that because I've been on the phone with people about that all week while I was here. IDSA is supporting Pasture. Partnership Fighting Infectious Disease, which is a conglomerate of a lot of organizations, industry, research, and others, are supporting both Pasture and Forward. Advocacy is the answer to a lot of the questions that I've heard in this kind of session. Obviously, as physicians, clinicians, researchers, advocacy is not your main concern. It's not your area of expertise. But there are things like there's a letter going out from California, there's a letter going out from Arizona, hopefully one from Washington, hopefully one from Texas, that will be from organizations, researchers, clinicians, and patients advocating for this and other research funding. So you don't have to be the leaders on it, but MSG and other groups need to be partners on it. And I think that's an opportunity for each of you to just add your name and just you don't have to yell, but you can just whisper that this is important to me. And that's all that needs to be done.
Thank you, Rob. Any comments? All right, so the plan going